Welcome to the Vanderbilt Eye Institute's Video Atlas of Retinal Diseases. This will be an introduction to the presumed ocular histoplasmosis syndrome. Presumed ocular histoplasmosis is one of the so-called white dot syndromes. It is presumed because there's been very little direct causal relationship of the disease itself with the ocular findings. Indirect evidence of the causal relationship comes from the distribution of clinical cases and the distribution of the histoplasmosis fungus in the soil. There are only a few cases of histoplasmosis found in the retina on post-mortem examinations. Here is a map of the histoplasmin sensitivity throughout the entire world. You can see this is older data. It was published back in 1971. Despite being worldwide, the ocular findings are found mainly in North America, with a few cases from Mexico, England, and the Netherlands. This disparity may be either a lack of reporting or possibly the genetic makeup of the populations in the different countries. If you look at the world map, you can see that most of the positive histoplasmin results are in people in the eastern U.S. and in river valleys throughout the world. Histoplasmosis is a fungus that lives in moist soil. During the dry season, when the dust is blown into the air, the spores go along with it. The spores are inhaled and then spread throughout the body. Scarring, presumably caused by the histoplasmin spore, has been found in the lungs, liver, spleen, and in eyes. I mentioned that while histoplasmosis can be found worldwide, there may be some genetic differences in the local populations, giving rise to this disparate finding between positive skin tests and the disease. Patients who have HLA-DRW2 is found in twice the number of patients with histoscars than patients without this HLA finding. Also, patients with HLA-B7 as well as the HLA-DRW2 are 2 to 4 times as likely to develop macular CNVMs. In the United States, the distribution is mainly in the Ohio River Valley and along the East Coast. The highest incidence of histoplasmosis is in Tennessee. While 60% of the population has a positive histoplasmin skin test, only 1.5% of the population has the typical retinal scarring. If a patient has scarring in the macular area, they have a 15% risk of developing a choroidal neovascular membrane. If the eye does not have a macular scar, then the patient only has about a 1% chance of developing a choroidal neovascular membrane. Other than just living in the Ohio River Valley and other endemic areas for histoplasmosis, what are the environmental risk factors? Well, the main risk factor not only is living in the endemic area, but is also in construction workers, farmers, and spelunkers. The last three are risk factors because these patients work in environments where the ground is disturbed, where the spores can come up in the dust, or they are in caves where they may be exposed to the histoplasmosis, which is found in bat guano. There is a classic histoplasmosis triad: peripheral, punched out scars, pigment around the nerve, and macular scars. All three, however, do not need to be present in an eye to make the diagnosis. Also, 5% of patients will have what is called streak histo in the periphery, and we'll show you some examples of that. The typical histospots are small, round, punched out lesions with sharp borders. They're about 0.2 to 0.7 disc diameters in size. Streak histo are linear circumferential, and usually found near the equator of the eye. Here is a fundus photograph of a patient who does have histoplasmosis. The nasal blue arrow points to the peripapillary pigment. There's also some scarring near the nerve off at 2 o'clock and some very small, a little bit atypical punched out lesions in the macula inferiorly. The lower right photograph has a bit more of a typical macular scar than the first examination. This patient will have a 15% risk of a choroidal neovascular membrane in 5 years. So this patient will have to be watched moderately closely. The upper left photograph has the typical punched out lesions. They can either be pigmented or hypopigmented. The upper right is an example of streak histo. This patient has more prominent pigment around the nerve in the right eye. Especially you can see this both at 12 o'clock and at 6 o'clock. And the punched out lesions are far more prominent than in the other example. Also note, unfortunately, this patient has a large macular scar, both hypopigmented and pigmented, directly in the fovea from an old subfoveal choroidal neovascular membrane. Now I'd like to show you some examples of streak histo. Again, they're in the equator. They can be pigmented or hypopigmented. And if you look, they can be very, very similar to lattice degeneration. Now, if you find this in someone who's moderately myopic, you may have a very difficult time telling whether this is histo or not. Histo is a choroidal lesion, so the lesions you should be finding at the level of the RPE, but a casual look, it can also look like pigmented lattice as well. The main complication that we worry about is the development of subretinal neovascularization secondary to a macular scar. In general, the closer to the fovea the origin of the neovascular membrane, the more likely there are to be complications and recurrences and a worse prognosis. In the past, both hot laser, PDT, and submacular surgery have been tried in the treatment of the neovascular membranes. In the next chat, we'll be talking about all of these treatments and the pros and cons and the long-term prognosis. In summary, in the United States, ocular histoplasmosis is found mainly in the Ohio River Valley and the East Coast. Tennessee has the highest rate. There's also a histotriad of peripapillary pigment, macular scars, and peripheral punched out lesions. 5%, 1 out of 20, may have peripheral linear streaks, and it's important to separate these streaks from lattice degeneration. If a macular scar is present, there's a 15% chance of that patient developing a choroidal neovascular membrane in the subsequent 5 years. Treatment nowadays for active neovascular membranes will be anti-VEGF injections. Rarely now, if there's a membrane in the macular area but far away from the fovea, you can still use the hot laser. If it's peripapillary, rarely submacular surgery may be a benefit. All of these treatments will be delved into in a more detailed in our next chat. And here's a list of references for you to refer to if you wish.